Joining us to answer your questions is Dr. Abid Fakhri, a cardiologist at the University of Maryland, Baltimore, Washington Medical Center. Doctor, thank you so much for joining us.
Thank you for having me on the program, Jeff.
Heart disease, nothing to sleep over. I mean, it's the #1 killer still.
Correct. So whether you're male or female, #1 cause of death in the United States and worldwide. We're talking in this case about coronary artery disease. That's the buildup of plaque within the walls of your coronary arteries, restricting the blood flow to the muscle, damaging that muscle, known as a heart attack. That damage, once sustained, can be life-threatening.
You think about the heart as being full of blood, and it's a shortage of blood that causes the problem, but how big are these arteries that we're talking about?
We're talking about the diameter of the spring in your pen, about 2 to 3 millimeters in diameter, so not a lot of real estate to work with. And that's what's feeding your heart with oxygen and nutrients that it needs.
That brings us to the calcium score test. Would you say that's increasingly popular?
Yeah, so I think CT calcium scoring is it's an interesting test that has grown in utilization for identifying who's at risk. Over the decades, we've traditionally relied on risk prediction with blood testing, like cholesterol, to predict risk. We know that misses the ballgame. CT calcium scoring is a simple, non-invasive test that can identify that plaque buildup in the walls of your arteries and help identify who might benefit from prevention with medication, lifestyle change, and sometimes intervention.
Is there a trade-off with the radiation that's associated with a CT scan, CAT scan?
Yeah, so most of the protocols that we're using for CT imaging for the heart reduce radiation dosage 70 to 80%. So we're actually able to get CT imaging of the heart with about a quarter of what you get from a nuclear medicine stress test or a CT scan you might get in a visit to the emergency department. So that trade-off is there, but I think that the benefit outweighs the risk.
Who should get one of these? What's the threshold?
Great question. So I think early testing, if you're in your 20s and 30s, may not make sense. In the same way, you may not go to get a mammogram until you hit age 40. CT calcium scoring may make sense for those people who are in middle adulthood. So men age 38 and above, women age 45 and above. And particularly patients who have risk for heart disease. That may be high blood pressure, high cholesterol, diabetes, or it may be non-traditional risk factors like family history of heart disease.
Symptoms? This is somebody with symptoms or without symptoms?
So we recommend CT calcium scoring as a screening for patients who have no symptoms, but are trying to understand their level of risk. If you have symptoms, you may actually want to take that scan a step further and do what's called a CT angiogram. It actually takes the calcium score a step further by giving dye through the arteries and actually it can show you the percentage of narrowing within the walls of those arteries.
And the base version of the test doesn't do that?
Correct. It's a screening test, but it's a highly accurate screening test.
Reminder, viewers, if you have a question about heart disease, preventing heart disease, send us an email to livequestions@mpt.org. These have been around long enough that you probably have data on this. Do they save lives? Do these tests help?
Yeah. So calcium scoring was first described in the 1990s. Arthur Agatston actually did the initial publication of this, so this has been around for 30 years or more. For every 12 patients with a calcium score over 100, we can prevent 1 heart attack or death from heart disease.
What typically happens after this test?
So your doctor is likely going to recommend treatment with statin medication. They may add aspirin to your regimen. They may talk to you about blood pressure reduction. And they're certainly going to talk to you about risk factor modification. That means cutting back on smoking, eating healthy, exercise, to reduce your risk for heart disease.
If you stopped 100 people on the street in my age bracket, how many people would have some calcium in their heart arteries?
Great question. So when we do these scores, we will correlate the amount of plaque to somebody your age and gender and ethnicity. So you can actually give a patient their percentile for their age. The older you are, the more calcium deposits you're likely to have. So it's important to put it into context of age.
Viewer question, this is Elizabeth. Great question. A lot of women have to take calcium for bone density with vitamin D. does that affect the heart and this test?
So vitamin D is actually protective for heart disease. Supplementation with calcium and vitamin D does not directly lead to calcification. Calcium deposits in the coronaries are actually old plaque. So where there's old plaque, we assume that there's fresh plaque. So that calcium deposit is not a phenomenon of calcium intake, but of stabilization of plaque growth within your vessels.
Does it make sense to repeat this test? I mean, if you put somebody on statins and let's test it again in a year, is it that sort of thing?
So we don't encourage repeat testing. The warranty period on these tests is very good. We expect that once you've established presence of calcium deposits, that calcium score is only going to increase with age. It's important to start treatment, set it, and forget it.
So how do you think about cholesterol now in the practice of cardiology? I mean, that used to be the Bible, right?
Yeah. Cholesterol still has a role. It provides a target for how aggressive you want to be with statin medication. I actually look at the cholesterol to know if my patient's getting a good dose of statin medication. If you haven't gotten 50% reduction in your LDL, there may be some room for us to intensify your statin therapy. So the calcium score gets your foot in the door. The statin is what makes the difference.
Anything new on the statin front in terms of, I mean, there's some medications everybody's heard about. Those are still front line?
So statin medications remain the front line. And the reason is that they stabilize not only cholesterol buildup, but they're reducing the inflammation within that plaque that makes them vulnerable to rupture and cause a heart attack. While other cholesterol medications may reduce cholesterol risk, reducing the inflammation is a unique property of statins. On that note, there are new and emerging therapies for reducing cholesterol that are actually very promising. Injectable therapies that can actually lower cholesterol 70 to 80%. So that can be an adjunct to your statin, but it may not replace the statin altogether.
What are we injecting in the injectable therapies?
Yeah, so they're actually monoclonal antibodies. Basically, you're teaching your immune system to bind to certain proteins, and by doing that, you're increasing the availability of receptors to bind up the cholesterol in your blood and take it out of your bloodstream.
On that very point, Deborah writes, I'm over 60 with genetic high cholesterol. Statins aren't working. Mm-hmm. Tried the shot but had bad side effects. What's next? She does not smoke.
So the first things, of course, a healthy diet, exercise. But there may be other prescription medications that are not statin. They may not be the injectables as well. There are other treatments that you can talk to your cardiologist about. As a last resort, there is something called lipid apheresis where they can actually siphon the blood, filter out the bad cholesterol, and filter that blood back in. This is only done at specialized centers, but that may be a treatment of last resort.
How much does diet play a role? I mean, she's tried everything. I'm sure that includes diet.
No, it goes without saying that a whole food, plant-based diet is effective in reducing heart disease risk. But for certain patients, there may be a need to go beyond just diet.
Viewer wants to know stroke risk is the question. Even if your calcium CT test is normal, does that necessarily rule out a stroke? Is that test useful for preventing strokes?
So strokes can happen for a variety of different reasons. Some of that, it's like a Venn diagram. Atherosclerosis can happen here in the heart, it can happen in the carotid arteries, it can happen in the brain. So some of that physiology is the same. Cholesterol reduction, blood pressure reduction makes a difference in both areas. But there may be other medical conditions that predispose you to a stroke, such as an irregular heart rhythm. That's something that a calcium score may not detect.
I read that you've been busy at the University of Maryland, Baltimore, Washington Medical Center. You're getting some new colleagues. You're getting a new cath lab. What's it all mean?
So we are growing. We're looking to expand services in Anne Arundel County. New cath lab, fully redone. We've started a new cardiac CT program, so we provide the full gamut of non-invasive as well as invasive diagnostic testing from start to finish.
For somebody who's not in the age bracket where you have a cardiologist or you would consider, absent symptoms, absent anything else, looking ahead to your later decades, what do you do in your 20s and 30s to prevent that plaque from getting started?
Great question. So I think it goes without saying whether you have heart disease or you don't. We all need to be following a healthy, balanced diet. Now, for some people, a whole food, plant-based diet may make sense for, for example, the patient that you referenced earlier. But for those of us who are just looking to get an edge on prevention, increasing our fiber intake, balancing the diet with lean protein, plant-based protein, getting a regular exercise routine, 30 minutes a day, moderate intensity aerobic exercise. Now, if you're looking to screen for heart disease, let's say you've had family history, there may be certain blood tests that you can do that go beyond your traditional cholesterol panel. That may be a specialized test that you want to talk to your doctor about. Something called a lipoprotein test, which for certain patients may identify something beyond a traditional cholesterol panel.
What are you looking for in that test?
So there's cholesterol can be broken down into.
I get confused on the HDL, LDL,
Absolutely.
but go on.
So LDL and HDL, those are traditionally known as your bad cholesterol, and your HDL is known as your good cholesterol. It scavenges up the cholesterol, prevents it from depositing in the walls of the artery. But we know if we break those cholesterol molecules down, there's more to it than just LDL and HDL. Lipoprotein can actually, it's not modifiable by diet alone. This is more a factor of how your liver produces cholesterol and metabolizes that cholesterol. And it may be something that's more genetic rather than dietary. So it can tell you about risk that goes beyond what your typical LDL might tell you.
Before we go, the message on the calcium score, the CT exam, who should think about getting it soon?
So big picture, age 38 men, age 45 women. Patients at risk for heart disease, not having symptoms, but are interested in finding out their level of risk.
Somebody not at risk, is there an age where everybody would be a candidate for this?
So I would say that if you're above those age categories, that's where I think the trade-off makes sense. Younger patients, not so much.
Dr. Abid Fakhri, a cardiologist at the University of Maryland, Baltimore, Washington Medical Center. Sir, thank you for your time.
Thank you, Jeff.